And this was another one in the UK where they took 30 seconds to say, have you thought of doing something about your weight? I can refer you. And 40% attended wherever they were sent. They lost a little bit of weight. It was good and it was acceptable. And we always think that, and I will use the word diet and exercise doesn't work. But these behavioural weight management programs are getting better. We're getting much better at them. And if you look overall, there are good results and people are keeping weight, except for this one, people are keeping weight off longer. So that's good. So for the lower end, these are good. And if you then add SMS messaging, as we did, 5 times a week at random times, Ian, have you remembered to walk today? Ian, have you thought about what you're having for dinner? Then weight loss continues. And it'll go out to a year, which is all that we had. It cost us 38 cents a day. A computer does it for us. And so if that doesn't work, then you can move on to the adjunctive therapies. And these are some of the drugs. Phentermine is around mostly. Liraglutide is approved. We use metformin off-label. There are combination therapies which are coming. We've now got Contrave in Australia, or will be this year. And then there are off-label uses of the SGLT2s and the SSRIs. I use fluoxetine a lot for emotional eating. 70% of women, when you talk to them, put on weight, not because their average eating is bad, but they go through periods of stress where weight goes up. And then this one is coming, semaglutide, and it's going to put the bariatric surgeons out of business. So when you use a drug for obesity, you must always use it with lifestyle modification. So this is the drug alone, lifestyle modification alone, just brief therapy, and combined therapy. So drugs work with weight management programs, in weight management programs. And you also need to choose the person to whom you give it. So this is an old study with Orlistat. If you gave it to everybody who had obesity, it wasn't very cost effective. But if you gave it to people with type 2 diabetes, hypertension, dyslipidemia, it was extremely cost effective. So again, you might be thinking of using drugs in those with the complications of obesity rather than simple obesity, shall we say. So here's the combination of phentermine and topiramate, and we're using this quite a lot because phentermine's cheap, topiramate's cheap, chop the tablets in half, so take half, and it works very well. And this is liraglutide, and I put this up because weight loss is pretty good, but not everybody responds to a drug. So here is, in 15% of those treated with liraglutide in this trial, didn't, in fact, gain weight. But some lost a little, more lost more, and 11% lost more than 15% of weight, and even on placebo, 3% did pretty well. But when you look at the new drug, this is semaglutide, and this is losing more than 20%. 27% of people on this drug, which will soon be an oral drug, lost more than 20% of weight. So you're getting up to obesity surgery. And the thought is that this drug, combined with something else, will take over. We hope, right? But this is quite impressive weight loss. And this is an old drug. This is leptin and pramlintide. And it works remarkably. I don't know what's happened to the slide, the graphs here, I'm sorry. But it does very well. And when you look at it, quite a lot of people are losing more than 10% in week 28. So, and this is coming back. There's a new trial coming looking at people with the genetic abnormalities of obesity and using this, and this will be quite effective.